इथे इथे रेंज रेंज आहे ना कमी पाहिजे. So we are live now.
हो सुरू कर.
Over to you, Shinde sir. We are live.
Okay. Thank you, Pradeep. Good evening, dear friends. I, Dr. Ajit Shinde, President of Maharashtra Orthopedic Association, welcome you all to this innovative MOA Masterclass webinar series. Today we are continuing a challenging topic, pelvic acetabular fractures. And today we are going to deal with part 2, associated fractures of acetabulum. For this program, we are having renowned masters in this field of pelvic acetabular surgery as expert panelist, Dr. Raman Umralkar from Jupiter Hospital, Dr. Pradeep Kotadia from Solapur, Dr. Nirbhay Tarandikar, and Dr. Pradeep Nemade, who is also going to moderate today's session. Today's case presenter are Dr. Srikant Deshpande and Dr. Aditya Kekatpure. In addition to this, we are going to witness various case scenarios which these experts not only have faced but also have successfully managed with their skills and wisdom, which they have gained after many years of practice. As mentioned previously, hip joint being a major weight-bearing joint and is indispensable part of everyone's day-to-day activities, proper reconstruction of these injuries holds immense importance eventually to decide the quality of life at the end. So let's now hear all tips and tricks from the masters themselves, which I think no one should afford to miss. So without wasting any time, I request Dr. Pradeep Nemade to carry forward the proceeding. Thank you. Jai Hind, Jai Maharashtra, Jai MOA.
Thank you very much, President sir. I must thank our President Dr. Ajit Shinde for taking such an interest and arranging all this masterclass series, which is really innovative and has given us opportunity to learn new things. We are today going to continue our SW series. That is the second part. Last week we have seen multiple case scenarios in the simple fracture patterns, and today we are going to go a step further and we are going to see the associated fracture patterns, and at the end of the session we are also going to see some complications. We're going to have a discussion on how to manage and prevent such complications in pelvic acetabular surgery. I must again welcome today's renowned faculty, Dr. Raman Umrakar from Jupiter Hospital, Thane, Dr. Pradeep Kotadia from Solapur, and Dr. Nirbhay Karandikar from Nagpur. So I would invite now Dr. Pradeep Kotadia sir to give us a pulse of wisdom in choosing the approach when we are dealing with associated fracture patterns. Over to you, sir.
Pradeep, and thanks MOA for giving us an opportunity to share our experiences in this field, which is a really complicated field. Today I'm going to deal with some of the approaches which are everybody should know when you are treating these difficult injuries. Dear friends, we know what are the goals in selecting any approach is a proper visualization of fracture geometry, allowing easy anatomic reduction and fixation of the fracture to achieve stability, restoring joint congruity. And it should be less morbid. This is the thing. Now about decision about selecting appropriate approach, that depends upon fracture pattern, local soft tissue conditions, presence of associated major systemic injuries, age and projected functional status of the patient, and interval between the injury to the surgery. There are many factors on which you are going to concentrate when you are selecting any approach. And of course, at the end, surgeon's expertise is very important. We should know proper all these approaches, the reduction methods and fixation methods to get a good result. It also, the decision also depends, is important to classify. When you are taking a decision, it's important to classify the fracture, whether it is a single axis fracture, which needs a single approach. I think that you have already dealt in your last case series or last series, that is a posterior wall or double axis fracture. That is, now we are going to go to the associated fractures, which approach you are going to use when you are dealing with this associated fracture. A single approach for both the axis fractures, or a single approach, a double approach for this. What are the indications for that? Commonly used approaches, as everybody knows, posterior approach, KL approach, KL with trochanteric flip, and modified Gibson's. I am not used to it. I think nobody, many of our surgeons, they are very well versed with KL approach. Anterior approaches are many, but nowadays maximum used approaches are ilioinguinal, iliofemoral, anterior intrapelvic approach, that is called as modified Stoppard's, anterior intrapelvic with lateral window, and anterior pelvic approach with iliofemoral, the dual approach. So these approaches are there. With the approach of AIP, now ilioinguinal approaches is taking a back seat because AIP is becoming more popular, where you can treat this complex fracture very well. Now single axis fractures, as I told you, these last time you heard about this, they are the posterior column wall or column with wall posterior approach. This is a standard, which is a workhorse for the posterior hastroid injuries. Anterior column, anterior wall, and anterior column with wall. Usually anterior approach is used. Any approach which is depending upon the fracture geometry, and transverse, a single approach depending upon the fracture geometry again. That we'll see in next few slides. Double axis fractures, like what we call associated fractures, they are complex fractures. Sometimes you use a single approach, sometimes you use a dual approach to fix these fractures. Sometimes in the same setting, you fix all these fractures in the same setting. Some people like to fix these fractures in sequential manner. Do first approach first, wait for some days, then do second approach. So there are definite steps, but I usually do all this in the same setting because it becomes very easy for manipulation as well getting reduction of these difficult fractures. What are the double axis fractures? They are the transverse with posterior wall, T-type, anterior column with posterior hemitransverse, and associated both column fractures. Now we'll concentrate more on the associated fractures. Single approach needs proper understanding of fracture geometry in complex fractures like associated fractures. A comminuted column or a more rotated part of this fracture is exposed by one approach, and either anterior or posterior depending upon. Second, a non-comminuted second column or second part of this fracture can be reduced by indirect methods. There are many methods to reduce these fractures. You have to bring the second part of this fracture, which is non-comminuted, to the first part, get a good reduction, and then you can pass with the interfragmentary screws. But the dual approaches are usually used when the both sides are very badly comminuted, or you are not able to get a good reduction of the associated fractures. By using single approach, don't hesitate to open the fracture from the second approach to get a very good reduction or a concentric reduction of the hip. Approaches which are commonly used, as I told you, they are ilioinguinal, iliofemoral, AIP, that is modified Stoppard, AIP with lateral window, AIP with iliofemoral, anterior as well as posterior approaches at the same setting, dual approaches. It depends upon the fracture geometry. Now we will see transverse fractures. I think whether this is covered in the last series, transverse fractures, I don't know. I think Pradeep will tell me whether they have covered the transverse fractures last series. So still I will cover it just to brush up what you know. This is a transverse fracture of the acetabulum where the axis goes in a transverse manner. So transverse fractures, when the fracture is displaced and rotated posteriorly. If there is a gap which is more posteriorly, you can see the gap is more here. The fracture is displaced more posteriorly. So this type of fractures needs a Cocker-Langman approach. You can see in CT scan, this is the anterior side, this is the posterior side. You can see the opening of the fracture which is more posterior. This needs a posterior KL approach to get a good reduction. This is one fracture, sorry, yeah, this is fracture which is approached from the posterior side and fixed with a posterior to anterior screw and this is a posteriorly fixed with a screw from posterior to anterior side. Okay, the fracture which is more rotated posteriorly, you can see here, the fracture which is rotated more posteriorly, fixed with a posterior approach and a percutaneous posterior to anterior screw fixing the anterior column. You have to approach anterior column by putting your finger through the greater sciatic notch, palpate the anterior column and see for the reduction. You can also use oblique clamps to get a reduction, to maintain the reduction till you pass a percutaneous screw. This is the way you fix the fracture. Now the transverse fractures which are displaced or they are rotated anteriorly, we have to fix this fracture by using an anterior approach, any approach which are your valves, ilioinguinal or iliofemoral or AIP, depends upon your expertise, whatever you can use the approach and fix this approach by anterior approach. Don't forget to put a antegrade posterior column screw to get a good reduction and fixation of posterior column also. So with single approach, we can fix this transverse, both elements of this fracture, anterior as well as posterior, using a single approach is anterior. Now transverse fractures with posterior wall is another entity which needs a Cocker-Langman back approach with a posterior to anterior screw. So this thing I just told you, when it is associated with wall, we have to use a posterior approach. Many times with wall, anteriorly you are very rarely you get combination, you get a single fragment and you can get a good reduction passing through your finger through the greater sciatic notch. Now we'll go to the next complicated fracture, T-shaped fracture, where the transverse elements comes just at the level, different levels, and a vertical limb goes either through the ischium or through the obturator foramen, and you get these two fractures, which is a T-shaped fractures. Now we have to know what is the morphology of this fracture. There are two distinct injuries, anterior column and posterior column. Both are separate. Posterior column may or may not be with posterior wall. Separate anterior wall injury. As the columns are not attached, all techniques of anterior and posterior column are applicable to this fracture. If the combination is more anteriorly, open from anterior side, then you put anterior plating, get reduction anterior, and put antegrade posterior column screw. The approaches which are usually used are anterior, posterior approach, AIP, both anterior posterior, depending upon the fracture geometry. When using a single approach, visualized column should be reduced and fixed, and then non-visualized column should be reduced by indirect methods and fixed with a lag screw if it is a single column which is there. So the approaches which are used for this type fractures are different fractures depending upon the fracture geometry. Approach to be used also depends upon the CT scan, combination of column, whether associated with wall or not. Now there are different methods whether to use anterior approach or posterior approach. It depends upon the vertical limb of this T fracture. If the vertical limb goes through the ischium, better to take a posterior approach to get a reduction. If the vertical limb goes through the obturator foramen, then anterior approach is used. The T-type fracture, you can see here, the vertical limb which is going in the ischium. You can see here the vertical limb which is going into the ischium. So better to use a posterior approach, fix this fracture by using a posterior approach. T-type of fracture where the vertical line goes through the obturator foramen. You can see the fracture which is here through the obturator foramen, which is very well seen here. Here, usually we use either anterior approach, either AIP approach is now routinely being used to fix this fracture, and you can definitely put a posterior column screw through the anterior approach and get a reduction of the posterior column also to get a very good concentric reduction. Complex type fractures where there is combination of anterior as well as posterior side column, then it is better to use both approaches and fix this fracture to get a very good concentric reduction. Now the next complex fracture is anterior column with posterior hemitransverse. This is the anterior column, posterior hemitransverse, some part of the articular surface still remaining with the acetabulum. This is a transverse limb and this is a vertical limb. So anterior column with posterior hemitransverse, common approach which is used is AIP with or without lateral window nowadays. This is the most commonly used approach for this type of injury, from where you can definitely tackle the anterior column with a plate and a posterior hemitransverse. Sometimes there is a fracture of the quadrilateral plate also. That also can be taken care of through this anterior approach. Sometimes you get dome impaction, which is there, also can be tackled with this approach very well. So whenever there is bone dome impaction, we have to use a AIP approach, through which you can definitely get a good dome impactions are disimpacted, and they are put a screw from there to get a good reduction of the dome also. The AIP approach with a lateral window can be used for these fractures and put a posterior column screw. This is a anterior column with posterior hemitransverse fracture, which has been fixed by using a AIP with a lateral window. You can see this fracture is fixed by using a AIP with lateral window, and a screw is passed in the posterior column. Antegrade screw is passed in the posterior column. So the most difficult fractures, they are the bicolumn fractures, which are very difficult to treat this. What is the bicolumn fracture? The fracture line goes above the acetabulum. The vertical limb goes either any direction. I am showing it is in the obturator foramen. It can go posteriorly or anteriorly. The two things are totally away. The acetabulum is absolutely not attached to axial skeleton, and it is a floating acetabulum that is called. So you have to get back that in proper position. How you are going to select the approach? The preferred approach for this is AIP with either iliofemoral with reduction of posterior column, if non-comminuted. To reconstructed, you have to bring the posterior column to reconstructed anterior column and then antegrade posterior column screw. If there is a lot of combination anteriorly as well as posteriorly, it's better to use a dual approaches in one go or sequential manner, but I usually prefer to go in a one go, for which I again stress that going in one go is a far better anterior to posterior, and the manipulation also becomes very easy. Sometimes we can feel the posterior column after fixing the screw might be coming anteriorly at the fracture site in the anterior column, and you not be able to get a good reduction of anterior column. That time, definitely, if you are doing it the same setting, you will be able to readjust the screws and get a good reduction, a concentric reduction. So my take is that I prefer to use these dual approaches in one go other than going. So this is a bicolumn fracture, which is a bad fracture. You can see a shattered fracture going up. So there is combination anteriorly as well as posteriorly. This fracture is fixed by using two approaches, anterior as well as posterior, with multiple screws and plates anterior and posterior to get a good concentric reduction. Another comminuted fracture, which is incomplete fracture going and so superiorly, has been fixed by using a AIP with lateral window and a posterior completely. This is the fixation of this fracture, getting a good concentric reduction. This is 6 months post-op, and this is a function of this patient. And then, in summary, dear friends, these complex or associated fractures needs a proper understanding of the fracture geometry, the dome impaction, the rotation of the fracture, the combination or a single part of fracture. Taking those part into consideration, we can definitely we can select approach. Anterior elementary fractures, as it has been taught to you last setting. Now associated fractures, transverse with posterior wall, KL approach with posterior to anterior screw. T-shaped fracture, either anterior or a posterior, depending upon the rotation and alignment, or a dual approach. Anterior column with posterior transverse. Anterior AIP is most commonly used this approach. very rarely, if it is associated, then and then you use a dual approach. Otherwise, with anterior AIP, you can tackle this approach comfortably. And the bicolumnar fractures, as I told you, depending upon the fracture geometry, you can select either anterior approach, AIP approach, or both approaches, depending on the, you have to judge the fracture and the fracture geometry. Thank you. Thanks for your listening. Thank you.
Thank you, Kurhadia sir. Thank you so much. It's good to see you here again.
Thank
Nirbhay,
you.
sir. How are you?
Thank you, Nirbhay.
How are you doing, sir?
Fine, Nirbhay. How are you? Doing well?
I'm still in Nagpur, sir. Today I just joined in for this program about 10 minutes late.
Okay.
I think your cases were pretty amazing, sir. I think, as usual, I'm amazed by the cases that you present. Pradeep is stuck in surgery, so we'll go on to the next talk.
Yeah.
Where is this gone?
We'll go to the presentation by Dr. Aditya Kekatpure.
Okay, Aditya, go ahead. Can you go on and present your case? You can unmute yourself.
Yes, sir. Yes, sir. Just a minute. So just a minute, there is some issue with the screen sharing.
Go on. Is there a problem?
Yes, sir. So screen sharing is not happening. Just a minute. So can we? Can I present after the other
Dr.
case?
Raman sir, would you like to present yours until he is ready? So you have to unmute yourself, sir.
Oh. No, I am not ready with any presentation. I was not told so.
Okay.
Oh.
I think Shrikant is.
So can you see this?
Yeah. We can see that.
Go ahead.
Go ahead.
Okay. So good evening, sir. I'll be presenting this case. 35-year-old gentleman. So he presented with the history of fall, and this was the X-ray on presentation. So the anteroposterior and the obturator oblique and iliac oblique views were suggestive of transtectal transverse fracture pattern. We went ahead and did CT scans. So it was suggestive of a break in the iliopectineal and ilioischial line. So, and the actual CT scan was showing a vertical fracture orientation.
Yes.
So I had planned for
vertical axial as well.
So this one is a fracture line.
No, do you have a vertical axial as well?
No, vertical axial view. So these are the views available with me right now.
Okay.
Hello.
Pradeep sir, anything specific that you would like to talk about this? Can we go back to the X-ray, please?
Yes, sir.
Yeah, you can say it is transrectal with the some part of the wall is also you can see here. Am I have to just see?
Sorry.
Yeah. As you can see here, some part of the wall is there. The transverse fracture which is there, and
okay.
I think that's enough. Then go to the other views. I would like to see the other views. Yeah, anterior column is not much displaced. It's an acceptable thing. A posterior column is much more displaced, I think so. So it is a transverse fracture. As I told in my lecture that the column which is most is displaced and rotated, you have to take that approach. So my choice of approach will be a posterior approach in this case, and fix this fracture by posterior approach, and put a finger through the greater sciatic notch and get a reduction of anterior column and pass a percutaneous posterior to anterior column screw, which is there.
Okay.
So that
Okay,
will
sir.
be my approach.
Okay, sir.
Aditya, this to me, this looks like maybe something like his hip was abducted and flexed at the time of the injury.
Yes.
So he was sure he had no other injuries around the knee.
No, sir. There was nothing over there.
Because hip flexion and abduction of the hip will probably give rise to this. So it makes me wonder as to what kind of a fall he had. Did he have a fall from a bike or?
No, sir. He's basically he was fixing the glass walls, and he had a fall. So basically a lateral impact.
Okay.
And when he had a fall, and that was the
All
mechanism of
right,
injury.
go on. Yeah, okay.
Yeah, that explains.
So as Pradeep sir told, I had planned for a similar approach, but I had planned from the anterior through the Stropas approach, and I had planned for a fixation of the posterior column with a ilioischial plate.
Why?
But because I had limited experience of putting a lag screw in the anterior column, but intraoperatively after fixing through the Stropas approach.
Can I interrupt on behalf of Dr. Pradeep?
Yes, sir.
Yeah.
I am Dr. Kale.
Yeah.
Hello,
Yeah.
No. Why did
Welcome.
you choose to go an anterior approach when the basic injury predominantly is posterior?
So actually, based on the X-ray and so based on the AP X-ray, and I thought that I would be able to address the posterior column also through the anterior approach. So I decided to go to the anterior.
Very difficult. It's very difficult even for the most experienced people to address a posterior column from the AIP approach. See, AIP approach is predominantly an approach for all the anterior fractures.
Yes, sir. Yes, sir.
No, I'm not trying to criticize you. We just want to know, why did you choose an AIP approach? One of the most difficult approaches of all the acetabular approaches. Why did you choose an AIP when you knew the predominant fracture is in the posterior aspect?
Aditya, I think what sir is trying to mention here is the fact, as what Dr. Pradeep was saying, that you need to reverse the vector of the injury per se. So if the injury has been, directed posteriorly with a lot of combination posteriorly, perhaps it makes sense to reverse that vector and go from that approach inward. Is that what he's trying to say, sir?
Yeah.
Kale sir, is that what you're trying to say?
No. What I'm trying to say is, when the major involvement is in the posterior column, I am trying to grade somebody from 5 years, 10 years, 15 years experience. I would do a KL approach, fix the posterior column. If I'm not very confident of fixing the anterior side, I would do a double plating of the posterior column and rely on that fixation for my anterior column. Secondly, if I fix the posterior column, I can very well pass an anterior column screw from the exposed KL approach.
Yes.
Okay, Aditya, shall we go ahead, sir? Shall we just see?
Yeah. I think we should go ahead.
So that is what I learned after this, and I actually fixed the anterior column, and I was not very happy with the posterior fixation because I was not able to. I had a lot of difficulty in fixing the posterior column through the Stropas approach. So ultimately, went through both the approaches, and this is what I did.
Okay.
And but was not very happy with the posterior column fixation.
To just give some suggestions, Aditya.
Yes, sir. Please.
The posterior column plate should have been a little bit longer.
Yes, sir.
It should come up to the ischium. The last two should go into the ramus, ischiopubic ramus.
Yes, sir.
Okay, that should be the ideal fixation in the posterior. These are just the suggestions which I'd like to give to you.
Yes, sir.
Nothing.
Thank you.
Okay. Remaining things okay. I'm very happy that at least you could go posteriorly and fix the posterior column. You are not left the things like that. So that is a good thing that you have done. At least you have fixed the posterior column. So now the hip looks quite concentric and seems to be a good thing. So good.
Yeah, one comment from my side.
Yeah.
What I think is the posterior column plates.
Yeah.
On each plate, there's only one screw in the ischial rami.
Yes,
Okay.
sir.
So
Yes, sir.
that makes it quite slightly unstable and inadequate. It is
Okay.
not that the two screws are passing through one plate. It is each one screw is through one plate. So that
So
one
if
plate single fixation is slightly inadequate. That is what it appears.
yes, sir.
So once you
Actually, the
start
plate length
mobilizing,
was the
yeah.
plate length choice was not adequate.
Yeah.
In this case.
Oh.
Yes. Yes, sir.
So preferably what Kothariya sir said, to get an ischial screw which is long enough right up to the tip of the ischium, and it may cross sometimes anteriorly also.
Yeah.
Bone, a tissue bone, that way also you have a good purchase. So aim for that always.
Yes, sir.
Okay.
Aditya, 1 second. Can you just go back to the CT in this guy?
Yeah.
Okay, stop. So I think, see, once if you are, once it is a fracture which is a transverse fracture, unlike a T. In a T, when the fracture line is exiting inferiorly through the obturator foramen, you might find that the posterior column fragment is completely separate, and you can do what you did by fixing the anterior column first. Once you are committed to fixing the anterior column and committed to reducing in a transverse fracture, if you fix the anterior column, there is no way you are going to get to reduce the posterior column if the anterior column is fixed, because it's a transverse fracture. This is not a T. In a T,
Yes.
you can perhaps go back posteriorly and rotate the thing and do that. Would you agree with that, Dr.
Yeah.
Pradeep?
Yes, sir.
Absolutely.
Once you fix the anterior column in a transverse fracture, there is nothing you can do to try and reduce the posterior column from the posterior approach again, because you've already committed to fixing the anterior column by a plate. It is not going to rotate on that. It is not, however much you try, the reduction of the posterior column is not going to come now.
Yeah.
True,
So
sir.
it is fairly superfluous to try to reduce the posterior column in a transverse fracture. If it was a T, definitely yes. In a T fracture, you will definitely be able to fiddle around and get a better reduction on the posterior column. Definitely, I agree with you on that one.
True, sir.
Yes, Dr. Raman.
Yeah. One more additional point. In a transverse fracture, if one column is not reduced properly, the other column also remains unreduced.
Exactly.
So hairline reduction is a must. And in a Stopage approach, you really require an excellent visualization of the whole fracture anatomy, and you would have had that the vision on table. So suppose if the anterior column is not reduced properly, you should not have gone ahead and fixed with it. If it remains in an unreduced manner, the posterior column also will remain in an unreduced manner. So in a Stopage, what I generally do is get a good reduction, that is first. You may have fixed the anterior column, and then to get a posterior column screw, you should have gone through the first window of the ilo-inguinal approach, rather than struggling through the same Stopage incision. Okay. I generally do not make an attempt to put a posterior column screw through Stopage, because you are retracting the vessels quite violently, which I am not in favor of. So I would go in from the first window and do it. So with the same position, we could have gone ahead and do the fixation of the posterior column also.
Okay.
I totally agree with Raman that when you are putting an antegrade posterior column, it is always better to take a lateral incision and be comfortable putting the screw, because you will be able to put the screw in a better position. I think that is a good tip Raman has given. When you are putting an antegrade posterior column screw, it is always better. For AIP, it is very practically difficult to put a screw.
So can I ask a question?
Yeah, sure.
So like in couple of cases when we have to address both the columns through separate approaches, so how to give patient positioning in that case? Like
that is a floppy lateral position you give.
So, but in floppy lateral, doing the Stopage approach is quite difficult, sir. Like, so any tips for that?
No, it's not that difficult. You have to make it as you are taking ilio-inguinal. You have to take it's a medial limb of the linguinal. You have to expose it and go to the Stopage. It's a straight position. You can get it, and then you can just turn the patient and you can get a lateral position.
Okay.
I think anybody has got any problem when you take a floppy lateral position and do an anterior Stopage as well as posterior approach? Anybody?
I'll make a suggestion.
Yeah.
Once you have to give a floppy lateral, make the patient first lie lateral.
Yeah.
Okay. You prepare the whole body.
Yeah.
Okay. Drape it.
Then make supine.
Okay. And then take out the sandbag from the posterior side and make the patient lie supine. Let the patient fall. So you go ahead and do the anterior approach, and then again flip it up. Your posterior part is already prepared, and go ahead with the posterior approach.
Okay.
Generally,
Raman,
sir.
it is we have got some supports, lateral supports, which are with our fracture tables. So that also can be used very well. Whenever you want to make it supine, just unscrew from the below side, and then you can make it supine, as well as you can make it lateral and again put a support. It becomes very easy. Number two, as you rightly said, pointed out, the preparation and draping has to be done in the lateral position only. And the draping has to be so nice that you turn patient in any direction and the unsterile area should not open at all. You have to take multiple stitches to keep the drape perfectly in that position. I think this is the crux when you're doing a floppy lateral position. Usually take not less than 15 to 20 minutes to take up different sutures to fix the linen to the skin, and then use a disposable drape, the hip U drape, to cover the whole area.
Absolutely.
Okay, sir.
Okay. Aditya, go ahead. You can go ahead.
So that's it.
You have got a follow-up of this patient?
No, sir. This is recently operated.
Okay. Okay. No
Yes, sir.
problem.
Yes,
So
sir.
the best part in Aditya this was
Yes,
that
sir.
you realized that the fixation of the posterior column is inadequate. You went ahead and completed the fixation.
Yeah.
That's the
Thanks.
best. So every case is a learning case. This also taught you something.
Yes, sir.
Yes,
Never-
that is.
Never leave any case unattended.
Thanks a lot, sir.
Yeah.
Pradeep sir, if you can please share some later time the lateral attachments you have got, it will be very useful for.
Yeah, sure. I'll just.
Fine. Thanks a lot, sir.
Thank you.
Thank you, sir. Over to Nirbhay, sir.
Now, the second case I think is going to show, Dr. Shrikant is going to show the second case. Shrikant, you have to unmute.
Yes, sir.
Nirbhay?
Am I audible?
Yeah.
Am I audible?
Yes, yes.
Yeah.
Pradeep,
We
sir,
can
am
hear
I
you.
audible?
Yes.
Okay. So I will share the screen. Is my screen is visible?
Yes.
Yeah. Now it is visible.
Hello.
Yes.
Presenting a case. I am Dr. Deshpande. Good evening, everybody. It is a case of a truly pelvic acetabular fracture. He was a 39-year-old male patient, had a fall from the height. He was suffering from a psychiatric disorder. And he presented with this X-ray picture to us.
Should I interfere, Shrikant? Should I interfere? You made
Yes, sir.
the
Yes, sir.
presentation is a full page. You can go down to the full screen, and then because you are showing go down. Yes. Sorry for the interruption.
Thank you, sir. Thank you.
Yes.
So X-rays were like this. X-rays here could not give us a proper idea how to go about it and what is the fracture pattern and all that. That's why that is also must thing. We gone for the next 3-dimensional CT scan, 3D CT scan. But 3D CT scan, it was showing iliac wing which was comminuted. There was the anterior column which was opening. Posterior column was relatively okay. But that was not the end of the story. Because here something we were missing. And we are gone for in the next step. At the same time, we ordered it. But as a next step, I am showing you, there is a gross comminution in the iliac wing. And there is a total vertical split extending down to the even in the region of the teardrop, vertical total cut in the acetabulum, along with there is a piece of a posterior wall. So not posterior wall exactly, it is a part of a ilium only. And this was some finicky fracture pattern. The fracture was extending in the anterior column here, and also in the there was a combination in the iliac wing. So now here, as there was a vertical split totally, this approach was dictated by the vertical split in the acetabulum. So we decided to go for an extensive iliofemoral approach. With the extensive iliofemoral approach, we have gone, and as it is a rule, we have gone for the peripheral fixation first. The iliac crest fixation was done. Then at the level of AIS, anterior inferior iliac spine, we have passed one interfragmentary screw, and then plate was applied after doing that extensive iliofemoral approach. And this is the post-operative CT scan. This is the post-operative CT scan where you can see these artifacts, but the fracture is very nicely, according to me, it is nicely covered. And this is a 3 months post-op follow-up of this patient. And at the end of 3 months, he was walking very nicely, sitting cross-legged, and squatting in a proper position. And here you can see the extensive iliofemoral approach, what we have taken. I wanted to ask Pradeep sir, whether we should have gone for additional AIP or something like that.
Go back to your X-rays and CT scan. You said this is a pelvic acetabular injury.
Yeah, actually, I am very. It was difficult for me to how to classify it properly. Can you throw some light?
Yeah, this is a purely a fracture which is there. Yeah, I think we can say this is either this is a biconal fracture or this is a T-shape. I will call this is a biconal fracture. Anybody who differs from my opinion?
The bicolumn, it is there. Yes, sir. What? Agree. There is an undisplaced posterior column. Yes.
So this is
undisplaced posterior column as well.
Anybody?
Transverse fracture with a this is I would say a transverse fracture with a huge anterior column.
So you, according to it, is a anterior column with posterior hemitransverse.
Yeah.
With this is you classified.
It may be the other way around. Anterior hemitransverse.
There is no entity which is described as anterior hemitransverse.
But then that is what is seen over here.
Yes, Nirbhay.
But I think, I would agree with what Dr. Raman is saying. The anterior column, there is definitely a posterior hemitransverse element to this. There is some combination there, but I would think that should be good enough. In fact, if you look at it, sir, it looks to me that the anterior column is the one which is the more displaced part.
Yeah.
And perhaps maybe simple AIP could have solved his problem, sir.
I think so. AIP could have definitely solved his problem. AIP with a lateral window.
Yes. And then AIP perhaps, sir, in fact, even the posterior column fixation, the fragment posteriorly
would have been a little bit easy because it's a single column.
It is not contributing to the stability.
Articular surface.
Yeah.
It is an extra-articular fragment rather than it is a intra-articular.
Yeah.
You can lift that also. You can put a screw from anterior to posterior side.
Yes.
So, Dr. Srikanth, you could get it what people are giving you idea?
Yes, sir. Yes, sir.
So, intrapelvic approach definitely will be a little bit better solution with a lateral window, and then you can start from periphery, come toward the center. Start from periphery, come toward the center.
Yes.
Then you can, as a rule. Then you can definitely, if you are comfortable, see the reduction of the posterior column. And if you're not getting a reduction of posterior column, you have to put either a bone hook or a collinear clamp near the ischial spine or in that area and get,
here
or you can use, you can even get unequal clamps to get a posterior column, bring it to the anterior, reconstruct the anterior column and pass a anterior to posterior screw, which will suffer. If you can, the ideal will be 2 screws in the posterior column because it's a huge chunk which is there. Better to use 2 screws. At least 1 screw should be there. So, anybody has got any different approach and any different way of fixing this fracture?
We use the same trick, sir, as you said. we put that unequal clamps from the greater sciatic knot to the anterior inferior iliac spine, but we use the outside approach, that is extended iliofemoral.
The extended, to me, the extended iliofemoral approach is usually indicated when you are dealing with the late fractures.
Revisions or late
presenting
fractures.
quite late to you, or Dr. C.P. Das uses it extensively for a malunited fracture where you go do a fracture osteotomy, realign it. I think he does it. He is very fond of doing this extended iliofemoral approach. For routine things,
to say frankly, sorry to interrupt you, sir, but to say frankly,
a little bit
hello,
overtaking.
Overkill.
Yeah. Yes,
but we wanted to take it. That was one of the reasons. Sorry, I am trying to.
You wanted to do it.
Larger picture.
Yeah, I wanted to do that.
Do we have a larger picture of this one, sir?
Yeah.
This one.
By any chance, do you have a little larger picture of the the post-ups?
I had it only. So how to do it?
Is it there on your laptop by any chance, sir?
It is there.
I think, sir, what we are discussing here from with Dr. Pradeep and here, I think a few of us would have a mainly inside and out fixation. Perhaps what you have done is an outside in fixation. Pradeep, sir, is that what we are debating here?
Which one?
What you and me are talking about is an inside-out fixation, like a stopa, like an AIP plus lateral window. And what sir has done probably is an outside-in. I mean, he has tried to go from outside and fix the inner aspect.
He has taken posterior here, like a posterior. He has taken extensor iliofemoral approach and gone posterior and fixed from posterior to anterior. You mean to say the same one?
No.
What you are doing?
No,
what
sir.
you are? Am I right, Nirbhay? What?
Sir, the way I was looking at this. Can you go back one slide, sir? A couple of slides.
This one.
Yeah. Sir, so if I were to say this, I would perhaps say that through an AIP approach, you should be able to put a joystick into the ASIS and derotate the anterior column fracture to get
it.
Okay. Then you could start from peripherally, start fixing up those plates, one plate there, one plate there. You would be able to put in a suprapectineal plate as well as an infrapectineal plate. You could also possibly fix the posterior column through an inside-out posterior column.
But
in one approach, which is a less extensile approach.
Less extensile, right.
We could have managed everything in this one approach.
I think
the point
we
I
can
would
definitely, you can definitely.
I think sir, what I find is that in these acetabular fractures, there is more than one ways to skin a cat. So there are many ways. Everyone can have a different opinion about how to go about it. But effectively, if we try to analyze the force vector, I think it makes it a little easier to figure out how we want to reduce the fracture back. Would you agree, sir, Dr. Raman?
One suggestion I would like to make.
Yeah, sure.
The pectineal eminence, there's a fracture at the pectineal eminence.
Yes.
The fixation that has been done, that has not crossed that fracture.
Right.
Which is why I was asking for that larger picture of the post-op.
So what the AIP would do, we could have got a fixation right from the pubic symphysis across.
Sir. Completely.
That was my concern.
So that would have been a better stable picture. Most probably, post-operatively, for some few weeks, this patient would have had some pain in the hip because of that not so strongly fixed anterior.
Right.
So that pain would not have had if you would have gone through that approach, or even through that modified iliofemoral approach. You could have gone slightly medially and put a plate over there.
Yeah. So right, sir, right. But taking into consideration, we wanted to do that extensile iliofemoral. In addition to that, patient was having gross psychiatric disorder. That's why we were a bit skeptical to do this IIP and all that, sir. I don't think that will interfere the results. But how about the post-operative picture, sir?
The results are brilliant.
Okay?
Absolutely brilliant.
Thank you.
Post-op CT is showing an excellent reconstruction of the acetabulum.
Yes, sir. Thank you.
That's right.
And the result is also showing very good, extremely good.
Absolutely.
Yeah. Thank you, sir. Thank you. Shall I log off?
No. Yeah. Go ahead, Shrikant. You're showing something. Hello.
Shrikant sir, you seem to have muted yourself, sir.
Dr. Shrikant?
Yeah, sir. Yeah, I'm on back. So, if the time permits, I will like to share other cases, or otherwise, I will do it
Go right ahead. Go right ahead.
End of the session.
All cases are very interesting.
Yes, sir. Wait. Yes. Yes, sir. I'm back. Am I visible, sir?
Yeah, you're not visible, but yeah.
So this is a now.
Yes.
Wait, I will make it a bigger picture. Yeah. So this is another case. A patient of 28-year-old patient. He was having a bicolumnar fracture with a comminution of the quadrilateral plate as well. As everybody can see, it is a classical bicolumnar fracture. And here 3D CT scan were done. 3D CT scan is showing the picture like this. Then here we have given a floppy lateral position. We may need to address both the columns simultaneously as discussed previously. Sorry for the inconvenience because I was out due to the internet problem for 10-15 minutes during Dr. Aditya's presentation. So I could not get your views at that time. Sorry. So floppy lateral position was given and simultaneous addressal were done. Actually, we did the anterior stopa with a lateral iliac window to fixation of that iliac wing. Then KL approach was taken to fix the posterior parts. This is a second case. Shall I stay on this case or
proceed? Go back, sir. Can you just go back?
Go back to there. Nirbhay.
Huh, sir.
Yeah.
I think you will be very happy to do this case with AIP because there is some dome impaction.
Yes, absolutely.
I think so. You will be very happy to do this with AIP and take either iliofemoral because the anterior column, I would like to see the CT. The anterior column is lateral to iliopecten luminous, or it's, let me see that. You got CT?
CT is there, but sorry, I have not copied all the parts of the CT. That transverse, actually, the transverse cut should have been copied by me.
Yeah.
We don't have we don't have a look at the anterior.
And there is a dome impaction.
Yeah. Retrospectively, I also feel so. But, sorry. But yes, I remember now. This patient was having a dome impaction, but it was on the posterior superior part, sir. And while taking the KL approach, we have just elevated it and then put the plate by buttressing that.
Okay.
Here the KL approach was taken, and then at that time, sorry, I remembered it later on.
I would like to show. I would like to go back to the X-ray of this patient.
Yeah.
Do you feel this? No, post-operative X-ray. Post-operative X-ray of this bicolumnar.
Yeah.
Post-op.
This is post-op.
Do you feel? Yeah. Do you feel this is a impacted dome which is not very well reduced here?
Yes.
Right. Agreed. Accepted.
You can see that. I have just annotated it with my name. So there is there.
Agreed.
I think
so.
Agreed.
Agreed. Yeah. Sure. I will take care in the next cases, sir. Thank you.
Yeah. Sure.
So this is the second case. She was having anterior column displaced and ilioischial line was relatively okay in this case.
Okay.
This is the CT scan. We can see the quadrilateral plate involvement as well as combination of the iliac wing as well. So here again, modifier stopa was taken. Relatively less displaced posterior column was there. So stopa with the iliac window was taken for as a suitable approach for this patient. And this is a fixation. Here I wanted to stress that we have used the spring plate to support the quadrilateral plate. This is a suprapectineal plate going up to the iliac wing. Then this is taking care for the iliac crest. And you can see the broken drill bit inside in between the two tables. I could not retrieve it on table, but I have left it.
That's okay.
Trying to admit that. Yeah. So, and this is a spring plate. What we have put, bend a routine recon plate in 90 degrees and given a buttressing to the quadrilateral plate from inside.
If you have done sorry to interrupt, if you have done an AIP approach, this quadrilateral plate would have been very well supported by an infrapectineal plate.
Yeah, yeah. Infrapectineal plate was not put. Yes.
Yeah.
That is a thought in retrospect. Thank you, sir.
In fact, sir, we have done a couple of cases in which we put, I love to use these spring plates. And I'm a big fan of using a radius T plate.
Yeah. That is a good option.
With with an additional infrapectineal plate, that kind of makes it really rock solid. I've been very happy.
Yeah. In next cases, I will try that tip.
Nirbhay, in cases when you're doing a radius plate, twisting radius plate, it's really a job which is very difficult job to get a very good a countering of this lower end radius plate.
Sir, it depends on what I think. If the plate is very thick and if it is a locking plate, it is impossible to do it. The non-locking T plates, they fit and they contour beautifully well, sir.
Yeah.
And it gives you, instead of like a recon will give you only 1 or 2 screws to hold the thing down. The T plate will give us at least 3 screws on the iliac wing, sir.
Yeah.
Hello?
But you have to rotate even at the iliac wing site also. You have to rotate the plate at
iliac absolutely
wing
correct.
Am I right? You just bend it. You just bend it.
Twist it. You need to twist it.
You have to twist the plate.
Bend it, fix it, hold it, put a couple of screws, and then the infrapectineal plate, sir. It works like absolute magic.
Okay. Thank you, sir.
Question to Nirbhay, sir.
Hello? Yeah, Aditi, go ahead. Shoot.
Sir, while putting the LST plate, so you first you reduce the fracture and then you pull the plate towards the iliac wing and then put the screw, like
So I normally reduce it using a ballpoint, a ball tip punch. Okay. And you'll get a rough idea how the reduction is going to be. Then you would put the plate and push the ball point and the ball tip pusher through one of the screw holes. So the plate and everything just sits beautifully onto the iliac wing. You can put a temporary K-wire or something to hold it in place while you put your screws in place. And it holds down pretty well, yeah. I mean, very happy.
What I generally do is I put a Steinman pin in the GT and pull it with the assistant pulls on it. The moment you pull it,
that is lateral traction.
Intraoperatively, that was used already. We put a chance pin in the femoral neck and lateral traction was given intraoperatively.
So the moment you give a lateral traction,
I think the trick is to pull the head out, sir.
Yeah.
Once the head is out, then the reduction becomes so much easier.
Very much easier.
Otherwise, it is impossible to push it back, sir.
Absolutely.
Yeah. So ours being a college hospital and many patients are for mainly Mahatma Phule Yojana. So this all the time it is not possible to do the CT scans. Actually, I would have loved to do the CT scans in a post-operative period. In some cases, I manage it somehow. Thank you. You can understand me.
Yeah.
And this is the case we already discussed. So I will skip this case.
Okay.
Yes.
And this is the case number 4. And here there was a posterior dislocation with a fracture of the acetabulum.
Yes.
And we can see in the X-ray, the head is gone up. This patient was dislocated in somewhere in Jharkhand, and then he came to our hospital almost 4 or 5 days later on. So
does he also have a infrafoveal pipkin, sir?
Yeah. Impaction.
Actually, impaction was there.
Does he have a head fracture?
Yes, sir.
Indentation.
Yeah. So now the CT scan showed, to our surprise, all the pieces were displaced anteriorly. To our surprise, all the pieces of the posterior, sorry, posterior superior part were displaced anteriorly.
Oh,
We can clearly see in these CT scans. The pieces, you can see these pieces are gone anteriorly. As you said correctly, sir, there is a infrafoveal impaction of the femoral head as well. And so here we plan for a trochanteric flip osteotomy to access these fragments, because these fragments are very difficult to access only with the KL approach, as all of you can agree.
Agree.
Yeah, so we gone for a trochanteric flip osteotomy, and some of the screws are interfragmentary screws, and in addition to that, buttressing to that those fragments, and this is the postoperative X-ray.
very well done.
And that impaction was left like that because it was not that significant.
Weight bearing.
Yeah, it was in a non-weight bearing area.
Very well
And
done.
now actually I will skip this case,
Sir,
because
can
this
you
is
just
a
go back one slide, sir?
Yeah.
I'm again reminded of what Dr. Raman said in the very beginning, that our posterior column plates need to go further down, sir.
But in this case particular, sir, if you see care, you can see that these pieces are just in the posterior superior part.
Okay, fair enough.
They are not
because it is,
extending down. So I have buttressed it up to here.
I agree with
This
you.
particular fracture geometry. Yeah.
I was
This
just
particular
wondering because
fracture
the hip
geometry
is so close to that area, that the head is so close to that area. I would be worried of penetrating the joint by those, by taking those screws in this area.
Yeah, Doctor, maybe I would have done that. I would have done that. I would have done it. I would have taken a longer plate and put a strong 2 screws into the ischium.
Into the ischium, sir.
Yeah. That is a good tip, sir. Thank you.
That makes it very strong fixation.
Yeah. So with
can you
Gans
go
osteotomy
back
also,
to the plane X-ray? Can you go
this
back?
is the plane X.
The
This
pieces are quite. There are a lot of comminuted pieces.
Yeah.
No?
And here the pieces are anterior to the
You
femoral
could
head.
fix
Here.
all the pieces very well. No, agreed.
Yes, sir.
Whether you could
Yes,
that the pieces are very well
there were
hold,
two pieces.
and they will be they are fixed with the screws.
Yes, sir. I can show you. So these
I
pieces
thought
were
there is a lot of combination. People, a lot of combination is there. People, they use a spring plate and then buttress. You can use a spring plate for this combination to hold, and then put a reconstruction plate on the top of, neutralize with reconstruction plate.
But here it was possible for me to put the interfragmentary screw avoiding the acetabulum.
Okay. No problem.
So here you can see these are 1 or 2 screws are fixing outside the plate with the washers. You can see. And even with this Gans osteotomy, it was very difficult to retrieve this, get these pieces back. They were having a strong soft tissue pull. So I wanted to ask the senior faculties. So what might be the pulling force for those fracture pieces?
Maybe an attempted reduction, sir, sometime. Someone must have
they have attempted. They have attempted in Jharkhand.
And
then once you have a fracture through the capsule connectivity may be intact. And while attempting with the capsule, it has gone anteriorly through the rent of the capsule. That is a capsular piece, capsular soft tissue.
Yeah, there was a strong capsular attachment. Yes, sir. I agreed. Okay.
So you can just pull it and it comes out with the capsule.
Exactly. Only if you tug it on the capsule, it comes out.
Actually, I skip this case because this is a pelvis fracture. It is not acetabulum.
Acetabulum fracture. Okay.
So can I skip this, or shall I go?
Yeah. No, we can skip this.
Okay, sir.
We can go to the acetabulum.
Next case is not this. This is last case for me.
Okay.
Okay, sir. Thank you.
Now,
here I have done this fixation.
Whether Pradeep has come back, or Nirba, are you going to talk about complications?
No, sir. I think I was just asked right away to talk about this. So just go ahead, sir. I think Aditya has one more case to show us, sir.
Yes, sir. So can I?
Yeah.
Yes.
Thank you, sir. So This was the patient presented with a dislocation, posterior dislocation, which was reduced in the casualty. And this is after reduction X-ray. And so sorry for the images. This was the maximum I could get right now. I'm not able to magnify this.
Okay.
So this was basically a comminuted posterior wall, and the column was intact in this case.
Is there any way dome impaction which was there posteriorly?
Yes, sir. So can you please guide me regarding how to address a dome impaction? Like whenever we are operating this, I have difficulty in visualizing that intraoperatively and managing that in my limited experience.
Yes, Nirbhay.
Yes, sir.
He wants guidance from you to get how the dome impaction should be corrected, how you diagnose and how you do the treatment of the dome impaction, which is posterior.
I think the easy way, Aditya, would be perhaps to use the head as a template for your reducing the dome impaction. If you flip the fragment open, you should be able to see the dome impaction. Use a small periosteum elevator to get it back into place and stuff some bone grafts below it. That is what has worked uniformly for me. It is extremely difficult to hold it in place. I have never tried to put a screw there to hold it in place, but I think that has worked pretty okay. And your dome impaction is best on your axial vertical X-ray array. I find it easy to see it on that.
Actually, these are the CT images I have right now, because patient came with these CT images and he was not willing for a further imaging study.
Wow.
So
can you just enlarge them?
Just a minute, sir.
Is there some way to enlarge those images?
Yes, sir.
Sound which is coming in the way.
Is this better, sir?
Not able to see the screen at all.
Just a minute.
Someone's mic is on and there's a constant disturbance.
Yeah, there is constant disturbance.
So now this is better?
Probably Shinde sir's mic.
Why don't we just mute ourselves except for Aditya and
Probably Ajit Shinde sir's mic.
No, my mic is.
We are not able to see the screen.
So I have shared the screen, sir. Hello.
Yes.
So I have shared the screen.
I am not able to see your screen. Aditya, I'm not able to.
Hello.
No.
So there is a lot of disturbance. Just a minute, sir. I'll again share, sir. So now it is visible. Hello.
At least I am not able to see it properly.
Nirbhay, sir, you are able to see the screen?
No.
Hello. Hello.
I think Aditya, you just stop sharing the screen, go back and again share.
Go back, yeah.
Okay, sir.
That will be better. You just
sir.
Now you can share the screen.
Now it is visible, sir?
Yeah, now it is visible.
Yeah.
Now it is visible.
So this is a zoomed image. Nirbhay, sir? Yeah.
there are some interarticular fragments which are
Yes.
there, small
Yes.
pieces which are there, which are not allowing a concentric reduction. And Aditya, dome impaction. Usually, whenever you open
Yes, sir.
any articular surface which is looking at you, take it that is a dome impaction.
Correct.
Okay,
Because
sir.
normally when you open from posterior side,
Yes.
you don't see a articular surface which is facing you.
Okay.
Okay, so unless and until it is impacted, and it is impacted, you don't see the articular surface. So whenever
Okay.
you see the impacted, as Nirbhay sir has told you, to put a periostimulator or a small osteotomy, derotate head as a template. And if the gap is too much, you have to put either a bone substance or a bone graft to support it. Otherwise,
Okay.
again, it
Go back to
recedes
its
back
own
after
Okay,
position.
sir.
Okay, some people use this 2.5 meter screws. Are they hardwood screws or cortical screws? Put it like a wrap screw onto that dome impaction so that it not go back. And on the top, then you put other pieces of the posterior wall and then neutralize with a plate like that. Okay.
Okay.
This is the way
Okay,
you
sir.
tackle the dome impaction. Anybody would like to add anything to the dome impaction?
What I do is,
Yeah.
around 8-9 millimeters away from the edge of the dome impaction, put a curved osteotome.
Yeah.
And with that 8-9 millimeter bone, with that curved osteotome, you hinge it and get it back onto the head.
Yeah.
Okay, so you have a gap of almost whatever the displacement might be. Suppose if you have displaced the bone fragment to say 1 centimeter, then you have a 1 centimeter gap above. That you go to the iliac crest, pick up bone grafts and put it over here. So now you have with the articular cartilage almost 8-9 millimeter of bone. So suppose if you put a screw compressing that over that this thing, the lateral plate, the lateral part of the cortex is going to be placed later on. So you imagine, you get it in mind the 3D perception that the fragment is gone in and the proposed track of a screw is 8 to 9 millimeter away from the dome impaction. So that holds the dome impaction there.
Okay.
Along with the bone graft.
Okay, sir.
So what I generally do is on table, I try to dislocate and see. If it is getting dislocated or dislodged, that means your fixation is not stable enough.
Okay.
So unless and until I don't attain that, the neutralizing plate I don't put.
Okay, sir.
What is this plate you have used? There are 3 plates I can see here.
Sir, it was a communicated fracture.
This is a plate.
That is a spring plate, I think. Evo spring plate.
Yes, sir.
It is Evo spring plate.
So it was from a local company. So I used it from Nebula. A spring-like plate was used, and then 2 additional plates I used.
Your plate length is quite good, quite adequate.
Okay, sir.
Very good.
Thank you, sir.
Okay.
This is the image. So in this case, I used a trochanteric clip osteotomy. So, hello.
Yes.
We can hear you.
Yes, sir. Sir, in this case, I used a trochanteric clip osteotomy because I was not able to visualize the fracture pattern properly. And
yeah, fair enough.
Yes, sir. And
looks very well done, Aditya.
Yeah.
Thank you, sir. Sir, and this is a new case, and I have not operated this case yet. And
wow.
So the patient presented with this X-ray. On this X-ray was taken on presentation, and then reduction was done. And these are the images. So shall I elaborate on the X-ray?
Yeah.
So there is a posterior dislocation, and there is a break in both iliopectineal and ilioischial line with fracture in the inferior pubic ramus, and there is some comminuted pieces seen on the posterior aspect. So to me, this is a transverse fracture of the acetabulum with posterior dislocation, and transverse fraction with a posterior wall involvement.
Would you like to revise your
T-shape.
diagnosis? Would you like to revise your diagnosis?
It's a T fracture.
Yeah.
Yes, sir. T fracture. Sorry.
This is a T fracture may be associated with a posterior wall, very small posterior wall.
Yes, sir.
Okay.
So this is
how
the.
will you manage now?
So I'm going to operate this case, sir, and I'm going to, as per your last talk, the displacement is more on the posterior aspect. So I'm going to go through the posterior approach using KL approach, and address the posterior column first, followed by the posterior wall fragment, and then plan for a lag screw fixation for the anterior column. This is my plan.
You have to be very sure that your anterior column is very well reduced. That has to be a first thing. You have to palpate it through prosthetic notch and see the anterior column, whether it's well. If you are not very happy, I don't mind you going anteriorly also and fix the anterior column in a better way, in a good way, rather than just passing a screw. Anybody would like to?
Does he have a sciatic involvement?
Sir, actually, he is having a calcaneal fracture also. He was having a compound calcaneal fracture, and the toe movements are very, yes, definitely he has a sciatic nerve involvement, sir, but not able to appreciate because the patient is currently on an external fixator for the lower limb, a joint spanning ankle fixator.
Okay. That needs to be documented before you touch the patient.
Yes, sir. Yes, sir.
I think the crux of this particular patient, the way I understand, is to get the head out.
Yes.
Once the head is out and you have a shank spin in the tuberosity, it should be, because the T fracture, you should be able to rotate the posterior column in a stable posterior column fixation on which you can build the anterior column later on by an anterior approach. I would not hesitate to take a dual approach for this one.
So sorry, not able to hear you properly. Hello.
What I said is that the crux of the whole reduction to me, as of now, seems to be reduction or removal of the head from its intra-pelvic position.
Yes.
Using a shank spin in the trochanter.
Okay.
Head is out. You should be able to put a shank spin in the ischial tuberosity and de-rotate the posterior column back into its place.
Yes.
Which will give you a stable posterior column.
Yes.
On which you can build the anterior wall by anterior column by using a second. Perhaps my plan.
Okay. Okay.
Do you agree, sir, Dr. Pradeep?
Yeah. Head has to be out first.
Once the head is out, the reduction should become easier, and if you can perhaps, I think, the superior part of the dome,
yes,
should be intact, and so getting the head under that should be your prime concern. Once that happens, the posterior column will reduce. You can plate it, then step anteriorly and go via a second dual approach. I would not hesitate to take a second anterior approach. I have a very low threshold for taking a dual approach.
Okay, sir. Okay, sir.
Dr. Raman, would you do something differently, sir? Dr. Raman, would you do something differently?
No. Absolutely right. Same approach I would have.
And I would agree with you on Aditya that you should do your KL first.
Yes, sir.
KL first, yeah.
Yes. We'll post the post-op, sir, soon.
Sure.
Once I operate. Yes.
Sure.
Thanks a lot, sir.
Sure.
Thank you, Nirbhay, sir, for the opportunity.
Thanks, Aditya. Should be an interesting case to do. Let me know.
Yes, sir. Yes, sir.
Hello.
Hello.
Hello, sir.
Hi, Pradeep.
Hi.
Hi.
अरे संडे को तो काम छोड़ दिया कर.
I'm really sorry for this thing. So
He is on
यहाँ पे
wheels.
सबका मीटर डाउन है, सिर्फ तेरा मीटर चालू है.
So I'll just be presenting a few of the complications, sir, and I would like to have the opinion of all the panelists. Just a second. Just as I'm opening my. So, pelvic surgery, very complicated thing, and we do have complications in this. And I think one of the most important thing is to know how this complication can occur and how we can prevent it. So there are few complications are pretty common, few are rare. Few can be very mild and few can be very catastrophic. So I'll be just going through few of the common complications, and we'll see how we can prevent and manage them. Just taking a little bit of time to open my presentation. Meantime, if there are any questions,
बंद करून परत तुला परत हे करतो का?
I'm working on sir's computer, so it's kind of running a little bit slow. So I can get the PowerPoint presentation on. Okay, while I am opening my presentation, I will just throw in questions for all the panelists regarding their DVT protocol. Starting with Raman Umrakar, sir. Do you like to give DVT prophylaxis each and every case, and what is your protocol of DVT prophylaxis?
All the patients.
I think very complicated cases with very complicated cases with if you're not going to mobilize them early. Number two is likely to have some problems then, and then only I give DVT. Otherwise, I don't give DVT for each and every case. Ajit,
Dr. Karandikar, sir.
Yeah, tell me, Pradeep.
Yeah. What is about your what is your DVT protocol?
It depends. See, most of my patients are done under spinal and epidural, so I like to avoid the epidural until the neuraxial anesthesia is in place. I like to keep the epidural in place with a syringe pump for post-op pain relief. So my DVT prophylaxis usually starts about 12 hours after the epidural is out. I would not hesitate to start a low molecular heparin for all of these patients, and of course I do not use compression stocking. I'm happy using a low molecular heparin and early mobilization if the reduction is pretty decent. Definitely risk profiling is also a good idea. So women, hypertensives, abnormal lipid profiles, perhaps I would be inclined to use that. Almost all my patients get DVT prophylaxis.
Hello, can't hear anything.
Hi. There's some technical, I think, voice is breaking.
Yeah, voice is breaking and there's a lot of disturbance in the sound.
Yeah. Tremendous disturbance. This disturbance is actually masking whatever we are talking.
True.
Yeah. Okay, so I'm going to show some cases where we have complications, and we'll see how each of them pair with what is the opinion of rest of the faculty. Just give me a minute. I think my screen is visible.
Yes,
now it is visible. Yes. Now it is visible.
So we know that we have intra-op complications such as vascular injury, intra-articular hardware, excessive blood loss, hollow visceral injury. We can have early post-op complications such as infection, DVT, nerve injuries, and then we can have late complications such as malunion, non-union, fixation failure, secondary arthritis, complications of moral level or heterotopic ossification. So this is a 23-year-old male in an RTA, suffered an acetabular fracture. He was in remote area. He presented to a distress place at around 3 weeks of post-trauma, and he was operated by, this is what is his presentation. He was operated by a very able paleo-acetabular surgeon. However, what was the problem in this case is that, the history we have to really take in, history with a pinch of salt. But it was done 3 weeks, this thing.
Can't hear you.
Pradeep, we are not able to hear you.
He found that, it is completely and trying to get the head back in position. We had this massive poster. Hello? Is my voice clear now?
No.
Hello, my voice clear?
No.
Just a minute. Hello, is it clear? Hello?
Yeah.
Yes.
Yeah. Sorry, because there was some network. I'm on a mobile hotspot. That's why. So this was it. It was how it was fixed. Unfortunately, we couldn't reduce the head. So regarding late presentation, Dr. Kothari, sir, what would be your way of handling a case that is, and particularly in this case, what would be your plan of management from now onwards? Now we are already around 1 or 2.
Now onwards, or you want first one? Now onwards or pre-operative planning?
Both, sir.
Both. Now onwards, I have to redo everything. Now also, and pre-operative planning also, I will definitely remove all the callus, try to mobilize the fragments. And in case I may use a femoral distractor to bring the head down, to get the head back to the acetabulum, and then relocate the head into the acetabulum, and then reconstruct the posterior elements which are there. The fracture seems to be a posterior leaf fracture which is going right down as well as superiorly. There is complete wall which is fractured from top to bottom, I think so. Am I right? Go back to the previous X-rays. Pradeep?
Yes.
Yeah. It is
Can you see now?
Yeah, but we are not able to hear you properly.
Hello?
Can you see it?
Yes, the whole
Yes.
posterior part has been totally gone. You have to go and mobilize the fragments. You have to remove the
Sorry,
callus,
because of my
mobilize the
poor
fragments.
net connection, I think there is some problem.
And I'll be very happy to do a trochanteric osteotomy. Pradeep? Yes, Raman.
Okay, sir, with such a persistently dislocated, internally rotated femur, will have a tremendous anterior capsular contracture.
Agreed.
That is the precise reason why you find it very difficult to relocate in a patient who have been in a dislocated stage for a very long time. So trochanteric flip osteotomy with an anterior capsule release, I think, is a must. Otherwise, the head, and suppose if you put a capsule in tension and reduce it, a very high likely that it can again re-dislocate. At the same time, it will put the anterior vascular structure also in a lot of tension. So capsular release is a must in this case.
So you have to go anteriorly to release the capsule, or you go.
You can go a trochanteric flip osteotomy. You can
go
see
anteriorly and release the capsule.
Yes, yes.
Am I audible now, sir?
A little bit. Yes.
I think there is a lot of internet connection problems. So this should be the last case, because I don't think so, I'm able to put the message through. So in this case, we are done the recreated fracture anatomy. Release all the capsule from the superior aspect. In the capsule we kept intact. We mobilize the fragment down, completely down, and then we part the two screws.
Yes, Pradeep. Pradeep. Meeting and I think, dear friends, I think Pradeep is not able to get a good connection. So I think it's almost we have overshoot the timing of our meeting by 5 to 10 minutes. So I think we are, Nirbhay, can we say bye-bye to meeting? Unmute yourself. Hello.
I think sir, it is 7 o'clock. Dr. Shinde, is the time for us to close down?
Yeah, I think so.
Yeah.
I think, can you hear me?
Yes,
Yeah,
very
yes.
well.
I think Pradeep is not having good connectivity as he is in Belgaum.
Yeah.
I don't know when he is going to be on screen. Should we close it?
Yes,
I think so. I think so.
I think so, yeah.
प्रदीप सर आप कुछ closing remarks दे दीजिए.
Yeah. Dear friends, it's a really good meeting to treat all these associate fractures by taking different approaches and different ways of fixation. I really thanks all the faculties who are present on Sunday evening, giving time to we all people, teaching them. And also, we are also learning through teaching also. So it's a really good academic meeting. I think I sincerely thanks all the participants also for attending this meeting. So I hand over this to Dr. Ajit Shinde to give a concluding remarks.
Thank you, sir.
It has been a fruitful discussion on associated acetabular fractures. Both the presenter, Srikant and Aditya, generated wonderful discussion, and all the expert panelists shared their knowledge, wisdom, and guided us right from how to classify the injury, how to choose the how to choose the approach and manage the fractures. And I think it is a much more nice experience for everyone who are listening this webinar. I like to thank presenters as well as the expert panelists, and special thanks to Pradeep Nemade and Dr. Sandeep Biraris, who are helping us for this audiovisual telecasting.